Hi, this is Brian Kim. I'm going to share with you this case of a patient who self-referred himself for a lens exchange. He had cataract surgery done elsewhere. About almost a year ago, noticed this shadow in this temporal vision, saw my YouTube channel and videos and thought, okay, I'm going to go see this guy. So he's coming from out of state and he's really miserable with the negative dysphotopsia. He has a single piece of acrylic lens in his bag. I went over all the details of what could go wrong and why we're doing this, and if he's really having trouble we should do it, but if not we should really not do it because the lens has been there almost a year. And he was very motivated to have something done, and so you're going to see me take this single piece of acrylic lens out of the bag and replacing it with a LI61AO lens with reverse optic capture. So you can see this is a ZC Blue lens, nice looking lens, and it's well centered. Thankfully, he did not have a YAG. He was smart enough not to have a YAG for this. And so you can see I'm making my incisions first on the right side and then the left side with my paracentesis blade. Again, the surgeon did an excellent job. Beautiful looking lens in the bag. This is some intracameral epinephrine and then some dispersive viscoelastic. He has excellent overlap of the rhexis. And this is my 3mm blade. Anytime I do a lens exchange, I want to use a 3mm blade. I make a vertical groove, place the blade into the deep part of the groove, tunnel, and then I'll enter. And why is that? Because one, it's easier to take the lens out, and then number two, this is a better incision for the LI61AO lens. And so this is my prototype IOL dissector cannula. It's flat, it's 27 gauge, and I have dispersive viscoelastic mounted on the back of it. And as I sweep and get underneath the rhexis edge, I'm able to push the viscoelastic in. So it's flat, it's blunt. So as opposed to using a blade or a needle, which is sharp, you don't want to do that. And so this is nice and blunt. It almost has like a hammerhead shape. It's kind of a bit rounded and more girth to it on the sides. So I'm able to sweep and get underneath the rhexis edge, and you want to pay particular attention to the optic haptic junction. That's where it's particularly sticky. So as I'm pushing the viscoelastic, I'm trying to tease the anterior and posterior capsules manually with the capsule dissector. And then I try to get under it and pushing some more dispersive viscoelastic into the bag. And you want to create some visco dissection between the anterior and posterior capsules. And you want to go all the way around when you do this. Very important that you don't overfill. That's why I'm burping some viscoelastic as I go. So I'm going around circumferentially, 360 degrees to peel the anterior capsule off the lens and trying to dissect a little bit deeper into the capsule fornix. And here I'm getting underneath the lens. I'm going to push some viscoelastic underneath the lens as well, as you see here. So just creating a little barrier between the posterior capsule and the lens. And then using a Lester hook, I'm going to try to see if I can free up this haptic. This is the trailing haptic. You can see it's somewhat loose, but not all the way loose. It's still tethered at the tip into the bag here. I don't want to be too aggressive, so I just let this one go now. I know it's fairly loose, so that's a good sign. And then I go after the leading haptic, contra-incisional haptic. You want to make sure there's space because as you're poking around, you don't want to actually puncture the posterior capsule. So that's why the viscoelastic is so important here. Grasping the haptic on the outer edge. As I pull it up, I also have some micro forceps in my left hand to help assist if I have to. Very carefully peeling it up. And I was able to pop the entire haptic out of the bag. It'll pop back in now. So I'm going to try to tease it again. And then using forceps, I grab the haptic and then pop it up into the angle. Do the same thing on the other side now. I'm going to push that leading haptic into the angle. And then grasping the edge of the optic, pulling it up with the Lester. Then I'm able to tease a trailing haptic into the angle. Using these micro forceps and the serrated IOL holder, I'm going to position the lens where I want to cut it. I like to cut it right to the left of the haptic, right there, the optic haptic junction. So I cut all the way, making sure I don't accidentally cut the anterior capsule. That would be horrible if I did that. That would totally defeat the purpose. So being mindful not to cut the capsular rhexis edge. So cutting the lens completely. With the forceps closed, I just tease the right side piece towards the middle and then grab it and pull it out. And then I'm rotating the left side piece 180 degrees. And then I grasp the cut edge, and as I pull it out, the haptic will collapse on itself, and I'll be able to remove the lens. I had the non-serrated forceps, and then the lens started to rip as I tried to grab it. So I switch hands. And now I have the IOL holder in my right hand grabbing the lens. Because it's serrated, I'm able to have a little bit more leverage and pull it out completely. This is some cohesive viscoelastic that I'm pushing into the bag. And this is the LI61AO lens. Again, this is the larger incision, a 3mm incision. So the actual cartridge doesn't matter so much. It actually matters more about the incision. So as I go in, the haptic is going into the bag. I'm making sure the bag is completely inflated with the cohesive viscoelastic. Because the incision is larger, regardless as if you use the 2.4 or the 2.8mm cartridge, it doesn't really matter. So you saw how very gently it came out planar, nice and smooth, without that abrupt delivery. So again, the abrupt delivery has less to do with the injector and more to do with your incision. So this is a 3mm incision. I go underneath the lens, removing all the viscoelastic from within the bag, and then using a one-handed technique with irrigation on, I just lift the optic up, anterior to the capsulotomy, creating a buttonhole configuration, removing all the viscoelastic from the anterior chamber, going back underneath the lens, removing the viscoelastic and making sure I'm in reversed optic capture. Again, that means the haptics are in the bag, but the optic is through the rhexis opening, creating a buttonhole configuration. That means the optic is anterior to the capsule plane, and by being closer to the iris plane, this helps reduce the negative dysphotopsia phenomenon. Push BSS as I go in, disengaging the irrigation, and then I'll hydrate my incision. So again, this patient traveled from out of state, found my YouTube channel and my discussion of negative dysphotopsia and how to manage it. He decided to come see me. He had a ZC Boo in his bag. Perfectly executed surgery. Surgery was close to a year old. I told him that I felt confident we can still take it out, but of course there's no guarantees because I didn't do the original surgery. Thankfully, the original surgeon did a great job cleaning the bag up. It was very easy to get the lens out. I used that prototype capsule dissector, which again is not really available yet. I've developed it with Epsilon, and at the flat 27 gauge cannula, you're able to get underneath the rhexis edge very easily without worrying about accidentally ripping or cutting the anterior capsule. You push some dispersive viscoelastic to get underneath the capsule and creating separation between the anterior and posterior capsule and getting the capsule off the lens. And then as I push more, 360 degrees, I use that dissector to try to peel the optic haptic junction from the capsule material. And then once I get it sufficiently separated, I go underneath the lens, push some more dispersive viscoelastic to separate the lens from the posterior capsule, and then dial each haptic out with the Lester as you saw, and then using micro scissors and forceps, cutting the lens in half, pulling it out in a strategic manner next to the optic haptic junction so the haptic collapses on itself, and then placing the LI61AO lens into the bag, the haptics in the bag, and then getting underneath the optic, prolapsing it up into the anterior chamber as I withdraw the INA handpiece. This patient came back post-op day 1, and he gave me a big hug. He was very happy that the dysphotopsia was much better. Of course, I warned him that it wasn't going to go away completely, and he admitted that it was still there to some degree, but far better than it was before he had his exchange. Anytime a patient has negative dysphotopsia, it's important for patients to understand that's just part of the lens. It's not that someone messed up the surgery or that there was a complication. I tell people having the lens in the eye, it's an artificial lens, and therefore your brain and your body aren't completely used to having a plastic lens. And some of the side effects of having a two-dimensional lens as opposed to a three-dimensional natural lens, a two-dimensional implant lens, this is one of those side effects. And so the good news is most people adapt to this problem, but when they don't, I can perform an exchange by removing the single piece acrylic lens and placing the LI61AO lens in the bag with reverse optic capture. So I hope this was helpful to you, and I thank you for your attention.